Med Pharmacy. Condios. Okay, Condios. Condios. Condios is from River State. Congratulations. Representative of CMed Pharmacy. Okay. Cross River. Okay. Okay, it's finished. Thank you. Thank you. Please clap for them so that your own can come. With that, we move quickly to the next aspect of why we are here. And of course, we have a lead discussant in the house. The man that we know is our own professor. Professor of... Many of you might not know. He's a man that practices action learning. You might think he's not a community pharmacist, but he's a community pharmacist by excellence. On Monday, he was giving you insights into some of the projects he's involved in, which are in the billion range. From a vantage position, I can tell you that he's also into chain pharmacy. So he has done research to see to it that how can community pharmacy practice really entrench into the community sector that we find ourselves. And of course, today, the result of those research will be revealed to us. Without taking too much of our time, I want to call upon our own professor of community pharmacy, forget about marketing now, Professor Larry Bale, the lead discussant for today's plenary section 1.
Thank you. So that it will be possible for you to see me, I won't stay there and I will stay here because of my height. So some of you are shorter than me and you are laughing. God sees all of you. We did a survey among the community pharmacists. The survey is about community pharmacist survey on public health services. Then the second survey is as relates to the activities of the development partners. So this first part, I will go through it in the next few minutes. And the second part, I will go through it. Once the slides are, but you can be assured, the slides are available for all those who registered, and they have email addresses. It will be made available to you. In the survey, the first question is, as a community pharmacist, have you been part of any NGO or donor-funded intervention in public health? About 37% said yes, and about 63% said no, which means large number of community pharmacists are not yet involved in terms of working with NGOs or donor-funded interventions. These are opportunities for us to render professional pharmaceutical services. Now, if yes, what is the name of the NGO or affiliate? Large number of them, about 27%, said that they've worked with Acpn. The next biggest is about 12% have worked with Family Health International. The third, Howard University Global Initiative, which I think who are the drivers of the COPA. I think as I mentioned these partners, let's give them a round of applause. At least they are intervening. Then Society for Family Health, about 10%. Shops, about 6%. NU. Drug abuse is about 2%. I think drug abuse is very low, considering the enormity of drug abuse afflicting over 20 million Nigerians. So I think that's a big opportunity for us. So in terms of counseling, in terms of medication, therapy, 1.6. What is the scope of the intervention? The biggest scope of intervention is patient counseling and education, followed by dispensing, and followed by referrals. The others, in smaller contribution, are testing, follow-up schedules, family planning, counseling and capacity building, and access to finance. Were you trained for the intervention? 94% said yes. Only about 6% were not trained. How will you rate the methodology of the training? About 33%, 1/3 will rate it as 5 all over 5, very effective. Another 33% will rate it as about 4 all over 5. And another one will rate it at about 25% will rate it at about 3 all over 5. Less than 10% will rate it at 1 or 2. How will you rate the knowledge and skills in relationship to your practice? About 28% rated it high. About 50% will rate it 4 over 5. And only about 22% will rate it at moderate. How will you rate the patient satisfaction and outcome of the intervention you provided? Over 92%, about 92% believe it's rated with high satisfaction of rated between 4 and 5. And only about 8% will say the outcome is satisfactory level is average. What are the other areas of public health intervention you think community pharmacy should be engaged at? One, because the developmental partners are here, this is where the community pharmacists need support and help. One is immunization, which will cover training and logistics, provision of access to the various materials for immunization, so that mothers could routinely go to community pharmacies for immunization. It's already happening in advanced countries in the West. And these people are not better trained than us. There's no reason why development partners should not help us in this area. The second thing is family planning. I will recollect that years ago, I worked for sharing. And we had a number of products like Anovla, Mynovla, Gynovla, Eugyno, Logyno, Microgyno, Sharing Tea, and a couple of family planning products. And you could hardly find it, you will find large number of it in the family planning, the parental federation pharmacy, where they pay, even though that of parental federation was actually free. It was clear that people have greater confidence to go to community pharmacies for family planning than for them to go elsewhere. For development partners that are in charge, that have part of their services to covering family planning, I think the community pharmacy is about one of the best healthcare professionals you could use. That real experience I had years ago confirmed beyond reasonable doubt to me that the community pharmacists can do a lot in this area. TB, we need help on TB. We need more support on HIV and AIDS. Malaria, we've seen the evolution in the malaria therapy. We have some medications that were treated earlier as ethical are now treated as pharmacy drugs, and so pharmacists can make recommendations. And the first point of call when people have malaria is usually the pharmacy shop. We expect that the community pharmacy should be actively involved in the management of malaria. So development partners who help us in this area, who also help us with vaccinations and with community outreaches. Particularly, we could divide the 52 weeks of the year into 52 major diseases that we think are the top diseases in the world, particularly in tropical land like in Nigeria, and have a specific week for each of the disease area. And so people who have those diseases, either for free counseling or for education concerning these disease conditions. This is the end of the first presentation. Please put on the second. The second thank you for clapping. Thank you. Clapping is for many of you who are not clapping is very good for you. It improves your cardiovascular system. So you better
clap now.
And
let's give him locomotive clap.
Thank you, Gary.
Locomotive clap.
Locomotive clap is not pa. Locomotive clap is you do 5 first, then you do 4, then you do 3, you do 1, 2, then you do 1. So we start with 5. 5. Pound, 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 pound. Second, 4, 3, 4. 3, 1, 2. 2, 1. That's enough. Those of you who still refuse to clap, my prayer is that by tomorrow your height will be my height.
Negative clap because he's called negative when he was in school.
Look at him. You know, I can't talk against the chairman. He will remove me from the high table. And this is the only place I stay, and I'm higher than other people. Let me enjoy it. The second is a survey we did specifically on the development partners by the Acpn. How will you describe a community pharmacist? The community pharmacist, these are their description. A pharmacist who provides pharmaceutical care within a pharmacy premises located in a community. Is a registered pharmacist that provides care, or a trained pharmacist or associate providing services in community through an outlet, or one working in retail outlets within the community. As the organization ever engaged community pharmacists, the development partners, 80% of them have utilized community pharmacies. I would like to thank them. And we pray that they will have no regret engaging us. If yet, let's clap for them. And many of them are here today to support this session. If yes, what area of the public health intervention, FP, which is basically family planning, account for 45%. Second, malaria, 22%. Post-abortion care, 11%. TB, 11%. And HIV/AIDS, 11%. What was the occurrence of the engagement? 25% said it was in the past, historical. Current was 50%. And planning in the nearest future accounts for another 25%. What was or is the scope of the intervention? About 1/4, essentially patient counseling. Another 1/4 referral. Another 1/4 is essentially dispensing of medicine. And about 12% to 13% service delivery and family planning service provision. How will you describe the experience in engaging community pharmacists to provide public health intervention? This is the feedback they are giving to us. Some said it is mixed bag. Some community pharmacists are enthusiastic, while others are not. When development partners ask us to engage community pharmacists, and they come up with this kind of response, it's like we are throwing away opportunities to go to non-pharmacists. And this is a big opportunity for us to enrich the quality of services we render. So if we are privileged to be approached by any of the development partners, please see it as a privilege that you must maximize. So we do not want them to come back when we do this kind of survey in another 1 year for them to come up with the feedback of mixed bag. Most pharmacies are not cooperative, as they are not prepared for the clinical service provision. They are not interested in documentation of services provided, which is a big challenge within the community pharmacies. Like I shared with you 2 days ago, documentation is key. Without documentation, you cannot do business analysis. Some of the people who have collected certificates today, the difference between them and those who did not collect certificate, who are exposed to COPA, may be traceable particularly to documentation. Documentation is the only proof that you've done what is required. For many who are in the academics, you will notice the fact that you may be the best teacher. If you are not documenting the learnings, if you are not publishing papers, you will never be recognized as a professor. And it's for that reason that I feel that community pharmacists need to do more in terms of documentation. And some, in spite of this mixed bag of information, some find it very rewarding, and they are very professional. Some of us are very beginner, and they are engaged well in the project. A big round of applause for those who have. Does engaging community pharmacists produce, or is it producing the desired outcomes? 75% of development partners said yes. A big round of applause. If you don't know, maybe 25%. For me, it's not a failure. It's an opportunity for improvement. And we feel that whatever we learn today, we can throw it back. What are some of the lessons learned and the way forward? Number one, we need to scale up by getting more community pharmacists involved. We are not merely available for training. We need to spend time for training. That's the only way we can add value to our services. Community pharmacists are willing to stock and dispense genuine commodities if given the right education and tools. So that's why training is key. There's a need for pharmacists to take up additional services other than dispensing. If the only thing we want to do is dispensing, I do not want to be involved in things like counseling, medication therapy management. We do not want to be involved with administration or support for family planning. Then eventually other people will take our role. And these are just part of our primary roles. If you are only comfortable with dispensing, then we tell the registrar to change your certificate from Farm D or B Farm to maybe certificate in dispensing. I think that's the only way. We should be interested in more than dispensing. We also be able to, should explore other technology beyond dispensing to include consuming, learning materials, reading, interaction with other practitioners, healthcare practitioners, using technology to do more, and monitoring and evaluation. Next slide. I would like to say thank you to everybody. Next slide. I would like to, okay, that's the end. I would like to say thank you for the opportunity given to me. Chairman, sir.
Thank you. Thank you. Thank you, sir. He's still around we are going to have panel discussion. But towards the tail end of his presentation, he made mention of the fact that we need to create time for training, especially we community pharmacists, so that our roles can be expanded. And who is to let us know whether we have expanded role or not, than also one of us who is going to be giving us a presentation in a few minutes. And at the end of it, the registrar will now encapsulate it. You could see during the professor's presentation, he made mention of a lot of donor agencies and international partners that have been involved in community service through community pharmacists. Some training has been taken. Those training, at times, they are not certificated. And that's why the registrar is here. By the time he's giving his own presentation, you know, maybe we will need to be certificated about certain roles we are performing, so that it doesn't become who granted you the license to do this or not. We'll be able to address that. But before we get to that level, I have the pleasure of inviting Pharmacist Albert Udo to take us into some of the expanded roles that community pharmacists should be engaging. Over to you, my brother.
Good morning, everyone. I stand on the existing protocols. This is a bit of a recap for what the prof has just said. We've seen the gaps and opportunities available to us as pharmacists, especially community pharmacists. Then what are these roles that we should take? And then I'll be looking at that in the next few minutes. My slides are very few. I will look at what is the current situation now. Where are we? Now, we understand the Nigerian health indices is no longer news. High maternal, child and mortality rate, and all that. Then in this space that we're talking about, we have other stakeholders, which we need to understand, who are worried about those indices. We have the international partners, we have the WHO, we have the Federal Minister of Health, through the arms of the PCN, they are also stakeholders. So we pharmacists are not the only stakeholders when it comes to delivering universal health coverage. And that is why we need to understand that as those gaps are available, there are some people that are not happy about it and they want those gaps to be filled. And therefore, what should we do? Because we have seen some statistics. Now, right now, we're beginning to talk about tax shifting. Those are the new paradigms. Now, tax sharing and self-care. There's a publication by WHO this year that's talking about self-care. And then in other countries, both in Africa and outside Africa, there's ascendancy of primary health care. Then the question is, where are we as pharmacists, especially community pharmacists? But let's look at some very few statistics. Now, because this is important. Next slide, please. Because this is the slide I saw, the data I saw that really alarmed me. Now, in the drug distribution space, using the studies done on access to contraceptives, now we find out that 60% of the populace of patients access contraceptives through the private sector, while 30% got it through the public sector, and then 10% get it from other sources. Now, in analysis of the access through the private sector, which is where it concerns us, we discovered that, and we've seen that in this data, that 64% of the populace access family contraceptives through the patent medicine dealers. 64%, while only 18% access it through the community pharmacists and private clinics. Now, if you extrapolate this to the nearest whole number, this is 60%, 20%, and 20%. This is really worrisome. Like the last presenter said, if we're not careful, if you're not proactive, if you don't sit up, we are going to have a situation whereby other people, take over the space. Now, another issue that we need to look at, I'm not sure the technical team is moving my this thing, is the fact that the pharmacist-patient ratio, the Nigerian scenario. Now, the WHO gave a baseline that there should be 2,000 patients to one pharmacist. But what we currently have in Nigeria is 10,000 patients to one pharmacist. And now in this ratio, we have a gap of 8,000. How do we fill this gap? That is why other stakeholders are beginning to talk about tax shifting, tax sharing, so that to bridge this gap. Because if we have to fill this gap at the rate, since inception we have only 25,000 pharmacists registered, we need about 100,000 more pharmacists to be able to fill this gap. Then what do we do? Because if we see ourselves as stakeholders and as leaders in the healthcare sector, we will not be visitated as to what happens to us. We put the patient at the center of care. And then we now begin to look at what we need to do. Now, the statistics next, this thing that shows, this was supposed to highlight the challenge that we have. The density of patent medicine dealers in Nigeria today. Because a study was done in 16 states. And we find out that we have a high preponderance of patent medicine vendors in the Nigerian health space. Now, if we talk about universal health care, which talks about access, availability of quality, not only of products, but also personnel, this is very worrisome to us as healthcare stakeholders in the healthcare space. So what should we do? What should be the next thing that we should do? The new paradigms, we talk about tax shifting, tax sharing, and self-care. Now, under this demands new roles for each of us. And what are these new roles? It comes with new responsibilities, and it comes with new accountabilities. Now, we have the leadership role to play. We don't have to play catch-up. We don't have to be proactive. We have to be sensitive. We have to know what is happening in the health space and then take position, give leadership. Because we have what it takes to be in the communities. And we are the most healthcare professional trained, when it comes to drugs. So we need to take leadership. We need to have to collaborate with other healthcare professionals. We have to collaborate with them so that we are able to, deliver what it takes for improved healthcare for the patients. We need to also undertake advocacy. That's on the external aspect of it. We have to change, impact the change of policies to be able to improve the welfare of our patients. Now, on the internal aspect, what do we need to do? What are the new roles? What we should be doing? We have to shift from drug peddling, permit the use of that word. Transactional business, it has to be drugs. We have to start looking at pharmacare and services. Counseling is important. We need to also look at skilled business managers, because running a community pharmacy is not just about the professional and the technical aspect of it. It takes businesses. We have had situations whereby pharmacists have to complain, like what is going to be happening tomorrow on transgenerational pharmacies. You see a lot of pharmacies, they can't run their businesses to a sustainable level. So we need to be able to do this. Now, we have to undertake strategic expansion, because we can't train all the pharmacists that we need right now to cover the healthcare space in Nigeria. What do we need to do? We need to look at strategic expansion in ways of satellite pharmacies, in ways of the hub and spoke model, where you have a pharmacy that supervises around all other healthcare providers when it comes to tax shifting and tax sharing. We need to show leadership. These are ways we can show the leadership, and we need to build our capacities to be able to deliver this. Now, we talk about the universal health coverage. We talk about availability, accessibility, acceptability, and quality, not only of drugs, but also the healthcare practitioners. And when it comes to the drug space, we are the specialists. And we may not be able on our own to deliver all that it takes. We have to look at other things that we need to do, like we talk about strategic expansion. We have to train others to the minimum, and we bring others under our cover and be able to supervise them. Because what has happened here, though, over the years is that the pattern medicine that is running wild in the healthcare space are not properly trained. And you cannot just push them over because they have the number. In fact, they are more politically savvy than a lot of the pharmacy profession. So we have to adopt the carrot and stick method. Bring them in, supervise them, control them, keep them where they should be. The more we drive them away, the more they get into the hinterland and begin to do things that is hurting the healthcare space. So as leaders in the healthcare space, that's what we need to do. Next slide, please. Now, talk about the expanded role of the pharmacists in the primary care, the role with partners and other caregivers. We have to partner with patients and other carers. We dispense, we prescribe, even non-prescription products. Now we provide health promotions, screen and advise the public on self-care. It's important. We need to be clinically sound. Over the time, as we begin to talk about, as the tax shifting and tax sharing begins to deepen, you find that there's going to be new skills. Maybe in some drug administration, we should be proactive. And there's been complaint, like the last presenter said, the development partners are not happy. Sometimes they train the community pharmacists, and when it is time to deliver, when they get back to their places, they are no longer available. They are busy running after other businesses. So the training is wasted. And because they are stakeholders, WHO is coming in strongly. They want to change the dynamics. If they cannot work with us, if the training they give to us, the little that they give to us is wasted, they may have to look at what is available to be able to build the capacity to ensure that the health indices is wasted. So it's not just about being a community pharmacist, opening a pharmacy shop, and then out of them. Outside Nigeria, in the UK, I'm talking with a lot of friends, and the US, you lose money by staying out of your shop. If we understand that healthcare or drug delivery has to go beyond products to services, each time your pharmacy is not covered by a pharmacist, you're losing money. So whatever it takes, if you have to do locum and you make sure that your pharmacy is completely and totally covered 24/7, and the training that you have received is also applied, is on ground to apply, the better for the health space. Now, the role with healthcare system. How do we impact the healthcare system? We don't have to be onlookers. We don't have to be reactive. When policies come out, we begin to fight against it and struggle against it. We have to be proactive. We have to collaborate. We are at a vantage position where we are interfacing with the public. We understand what is happening with the patients, so we can give feedback to the healthcare system to design policies that will improve the outcome. So, and also the role with other healthcare professionals. Referrals to other healthcare professionals, collaborate with other healthcare professionals in recommending pharmacotherapy, drug therapy, and through education and research. So we are not fighting. We shouldn't be fighting. There are certain things that where our skills and our licenses stop. We have to, collaborate with other healthcare providers within our window of operation. This is how you take over. When you know when to send people to the lab, when you know when to send the person to the hospital, when you train the PPMVs to know when they should refer, either to you or to other places, you have shown leadership. The healthcare, outcome will be improved, and the other professionals will trust you, and will begin to work together. Now, we have to move from product-centered supply, as I begin to close, of medicines to patient-centered services. We have to shift from transactional to value-driven thinking. It's not just about how much am I making per capsule, per tablet. What else are you doing to drive value that will drive patients to your place, that will make the PPMVs to refer people to you? So we need to think about value-driven services. Integrate into the healthcare teams. Whatever is coming up that you know, knowing fully well that we are not the only stakeholders. There are other stakeholders. We have to integrate with them and then collaborate with patients in making healthcare decisions. Now, we have to be responsive to emerging trends. This is very important because we don't have to still sit on what used to happen in 1939. Things are changing. So we need to be up and doing. We have to be proactive instead of insisting on the status quo. We have to collaborate with other stakeholders. We have to skill up. We have to skill up. We have to skill up, both in clinical practice and business management. Pharmacy profession, when we were in school, we were taught the science of it all. But the moment a pharmacist stepped out of this pharmacy school, it's a different scenario. Sometimes I posted a situation that they begin to take leadership that they were not trained about. Some of them are put in situations where they have to manage businesses that we're not trained about. Now we see in some platforms that we belong, you see some pharmacies or some pharmacy setups having superintendent pharmacists and yet hiring a business manager. Because pharmaceutical practice is not just science, it also has to do with business. So we have to skill up. We have to learn what it takes to run a successful pharmacy so that these pharmacies can be transgenerational. Structures, strategies, and how to manage our clients. Finally, the illiterates of the 21st century will not be those who cannot read or write, but those who cannot learn, unlearn, and relearn, according to Alvin Toffler. And Steve Jobs had to say that you have to stay hungry. And I want to leave us with this food for thought. Uber has no taxi. Facebook develops no content. Netflix has no TV station. Alibaba holds no inventory. Abnix has no hotel. Now we have seen telemedicine. Now the question is telepharmacy loading? Are we prepared? Thank you very much.
Okay. The chairman of Acpn did not clap for our presenter. So he's doing his own. Thank you. You have really gingered us. He did inform that one of the areas we are lacking is documentation. If you have not documented it, you have not done it. And that is the crux of the matter. The professor read out all those international agencies we are interfacing with. If there are no reports to justify what they are doing, then you have not done it. He did inform also that we need to move beyond products to services. And in showing leadership, we must be proactive. Proactive and collaborate in the designing of policy We do not wait for policy to come and meet us and start reacting. We must be proactive and collaborate even in designing policies. And that's why we are here now. I hope we are jotting our questions by the time we are going to have the panelists discussion. We must move beyond our border. Thank God, at the master class for the MCPD, somebody from a dermatologist came to teach us. And we could see how relevant it was to. And now, value-driven services. This is what can help us to integrate into the healthcare team. And once we integrate into the healthcare team, then we have our regulator. The federal government is here. The representative of PMB, President Muhammadu Buhari, is here, who's going to give the seal of authority. And that's why he's the one that is speaking last among all the presenters. So I have the pleasure of inviting the #1 federal government public officer in our midst, the registrar of the Pharmacists Council of Nigeria, the double prophet himself, to give us his own presentation, which is on the role of pharmacists in community pharmacy practice. The role of pharmacists in community pharmacy practice. So once he tells us all these roles and whatever, then he's going to back it up with certificate. If we can do immunization, he will back it up with certificate. We can do family planning, he will back it up. But before we demand for those certificates, let us listen to our double prophet. Over to you, sir.
The chairman of this morning's session, the chairman of Acpn, I want to recognize some people who have really contributed to this presentation I want to make this morning. I want to recognize our consultant, who is always, anytime you meet him, he's always coming up with ideas. Pharmacist Larry Bale, I want to recognize you very well. And Mrs. Olalere, are you in the hall? Stand up. Where are your colleagues? Where is Ene? Okay. Those, sit down. Those are the people that are working behind the scene, so that whatever we are speaking this morning, it's not just coming from the registrar alone, but from other staff. I hope it's coming up. Or do we stretch our hands so that we pray to the screen, so that the Lord will deliver the screen?